Hello, everyone. My name is Dr. Michael Mamone. I'm a second-year internal medicine resident with Florida Atlantic University. I'll be presenting a case on disseminated HSV, presenting as acute hypoxic respiratory failure in an immunocompromised patient. My co-authors are Dr. Alicia Bird and Lila Tao, MS3. For the introduction, acute hypoxic respiratory failure secondary to herpes simplex virus is actually a relatively rare complication, typically seen in those with hematological malignancies who are undergoing chemotherapy. Those diagnosed with HSV pneumonia typically have a very prolonged hospital course, exposed to unnecessary antibiotics, as well as at high risk of being placed on mechanical ventilation. It's very, very important that early diagnosis is made, as HSV pneumonia is associated with a very high mortality morbidity rate of 75 to 100%. So as clinicians, we need to be able to identify those who are at high risk of developing HSV pneumonia and initiate therapy early on in the hospital course. So going on to our case, this is a 66-year-old female. She has a past medical history of recently diagnosed CNS lymphoma. She underwent 5 cycles of chemotherapy and was placed on prednisone. She presented to the hospital with altered mental status and acute hypoxic respiratory failure. On physical examination, she was hypoxic, febrile, tachycardic, sick in appearance. Her physical exam, she had diffuse vesicular rash on her upper lips, her face, her neck, her flanks, her buttocks, pretty much everywhere. Pulmonary exam significant for crackles on auscultation bilaterally, and neurologically she was only oriented to self. Labs on presentation was only significant for leukocytosis. COVID-19 PCR was negative ×4, actually. CT chest was done during her hospitalization, and this showed the severe interstitial multifocal pneumonia, pretty much panlobular bilaterally. And MRI brain showed improvement in her initial CNS lesion, however, no acute changes were present. The patient was started on broad-spectrum antibiotics with vancomycin, cefepime, and doxycycline, and antifungal coverage with diflucan, and she didn't really have any improvement in her respiratory failure. She remained on non-rebreather 15 liters for about a week and a half. And due to her worsening mental status, we decided to undergo a lumbar puncture, and the CSF came back positive for HSV PCR and no signs of bacterial infection. And given her prolonged acute hypoxic respiratory failure without significant improvement, despite appropriate therapy, a bronchoscopy was done, and the bronchial lavage resulted positive for HSV PCR, consistent with a disseminated HSV infection. So she was started on IV acyclovir. All antibiotics were discontinued. Following initiation of IV acyclovir, she had significant improvement in her respiratory status and skin lesions. However, neurocognitively, her status was relatively poor. Now looking over at our imaging studies, figure 1, the CT chest shows this diffuse panlobular interstitial multifocal pneumonia bilaterally, and comparing it to figure 2 after initiation of IV acyclovir, you'll see a very significant improvement in all these infiltrates, and this was clinically correlated as well. The patient was on about 2 liters nasal cannula at time of discharge. So going into our discussion, HSV pneumonia is relatively rare and has an increased incidence of about 3% seen with those with hematological malignancies, such as lymphoma and leukemia. So what are our risk factors? Those are those with hematological malignancies on aggressive chemotherapy and corticosteroid administration, as seen in our patient. When should you be suspicious for HSV pneumonia? This is really the teaching point here. It's those who are immunocompromised, not on acyclovir prophylaxis, and those who do not improve in oxygen requirements despite aggressive therapy, and this was all seen in our patient. Diagnosis is made by bronchiolar lavage, which is HSV PCR. Histopathology is typically seen on cytology. Management involves initiation of IV acyclovir, and without initiation, the mortality rates are between 75 to 100%, and this is due to a severe ARDS. Based off my literature review, I actually showed that you really only have improvement in your oxygen status with the use of acyclovir, but they didn't really see any significant effect on mortality or length of hospitalization in the immunocompromised patient. This may be due secondary to identifying this pneumonia late on in the hospital course, as it was a lower suspicion. So in conclusion, I thank you for listening to my presentation. I hope this heightens your senses for a possible HSV pneumonia, and now you'll be able to empirically treat it and diagnose it early on. Thank you very much.